Well, here we are. Welcome everyone to ThinkWell's Counterpoint webinar series. My name is Margaret Cornelius. I am a senior advisor at ThinkWell, and we're here today at our Counterpoint event to bring together new voices and ideas where we really push the frontier of thinking in global health and global development. We're going to give everyone a few minutes to sign on, so I will start the webinar officially at 8:05 Eastern. But as we get going, I just want to give a few remarks and some context points so that those who are joining can understand what we're trying to accomplish today in this event. So this is our second actual event. We're really excited to have everyone here today. And what we're talking about, as you know from the emails and the communication, we're looking at factors that drive decision-making about investment in immunization and how immunization financing can be sustained in middle and high income countries. This topic is emergent from a multi-year partnership with Merck & Company, also known as MSD, outside of the US and Canada. And we ThinkWell have been working with Merck and MSD for many years on understanding and developing solutions to immunization financing challenges around the world. We're so excited to have so many participants today. I believe at the last count, we had over 300 people signed up, which to me is a signal of how excited people are about this conversation and how important this topic is in the moment that we're at as a global community. For those of us who are joining, or for those who are joining the first time, ThinkWell is a health and development organization, global health and development organization that's working to strengthen systems around the world. We work with many different countries and partners, from private foundations to bilateral aid organizations to industry. And we really see ourselves as being committed to asking the hard questions as we pursue solutions to the chronic financing and performance challenges that health systems at all income levels face. Okay, as you know, today's topic is hugely relevant given the moment that we're in as a global health community. The COVID pandemic is raging. Vaccine equity is incredibly precious and incredibly distant even now, even with all of the resources that are being poured into it. And while we're collectively trying to end the COVID pandemic, we're also observing as a global health community many, many disruptions in routine services, from immunization to nutrition programs to HIV, to cancer care, to other chronic disease management. So as we think about how we can invest more and how we can get vaccines out faster to end COVID, we also need to think about how we can shore up systems and invest in public health infrastructure that will protect us all today and in the future, because we've heard from all the experts that this is probably not our last pandemic. Securing healthy communities through strong immunization programs is not something that we can just assume will happen. Even in high income settings and even middle income settings, we know that there are many performance challenges evidenced by coverage drop-offs, evidenced by low rates of what are considered to be very safe and very effective vaccines. So we know that there's work to be done, and we know that financing is a huge part of that. As the UN General Assembly kicks off this week, and as evidenced by all of the discussion at the G20, the White House summit that's being called for next week, we know that global leaders are listening and are very, very hungry to hear solutions about COVID, but we also know this is a major opportunity to grab the ears of policy and political leaders as we think about what investments in public health really mean. And we've all learned really painfully about what underinvestment in public health has resulted in as we continue to struggle to contain this pandemic. We're so thrilled to have 4 incredible experts joining us today, who I'll introduce more fully once we get started officially. But I know we're in for a really exciting conversation and a provocative debate about what really influences decision makers and politicians when it comes to immunization and immunization financing. So without further ado, I'm going to formally launch us off. I want to do a few quick housekeeping comments before we get started. One thing we'd really like to invite the audience to do is to add their questions to either the Q&A or the chat. We will be looking at these very carefully and making sure that we can capture a few of them towards the end of this conversation. So please don't hesitate to send us your thoughts and your ideas. And we'll be looking at them and summarizing them towards the end and asking our panelists to reflect upon your comments and thoughts. So I'm going to go ahead and kick off now that we're at 8:05. Hope everyone is still able to sign on. I see the attendee list bumping up. We're at 103, so welcome again. Again, my name is Margaret Cornelius. I'm a senior advisor here and I will be moderating this debate on behalf of ThinkWell. I'm going to introduce our panelists now, starting with our panelist, Dodo Banzon. Dodo is currently a principal health specialist with the Southeast Asia Regional Department at the Asian Development Bank. And as many of you know, he's the former CEO of the Philippines Health Insurance Corporation, also known as PhilHealth. Dodo has very graciously agreed to offer his perspectives about how multilateral financing institutions and how ministers of finance, ministers of health, and other relevant ministries think about investments in public health and immunization and how some of those trade-off conversations tend to happen. Bringing a hugely important perspective across Asia, which of course is a major population center for the globe, and also a middle income setting for the most part. So this is a situation where you have a lot of countries who are not eligible anymore for donor support and are really confronting major trade-offs and challenges when it comes to covering immunization and making decisions that will secure the health of their communities. I'm also happy to introduce Ulla Griffiths, who many of you know, and she's a senior advisor on immunization financing at UNICEF headquarters in New York, and also an honorary associate professor at the London School of Hygiene and Tropical Medicine. Everyone knows Ulla's research. We're so lucky to have her here today. And she will be sharing with us her views and experience about how evidence about vaccines and immunization factor into decision-making at the policy and political level, and probably more often than not when it doesn't, but it should. Our third expert is Stefan Swartling Peterson, who of course is well known and beloved by the global health community. We're so happy to have you here, Stefan. Stefan and I worked together on a major project in Uganda many years ago, and I've learned so much from him over the years, and so it's really a pleasure to have you here today. Stefan will be sharing his perspectives on how health systems are organized, and of course from his perch as the professor of global transformation for health at Karolinska in Sweden, and now as an advisor to UNICEF Sweden as a health specialist. He has so much experience to share, and we'll talk about how health systems are organized, or in some cases disorganized, to provide preventive services like immunization, and how vital these services are to the broader global effort to expand and strengthen access to primary health care, including immunization. And finally, I'm really excited to have Catherine Goode here of Goode Strategies. Catherine has spent her career working on advocacy in global health and even US healthcare, from the MNCH team at the Gates Foundation, where she and I first worked together, and to working on Capitol Hill in the US on healthcare policy and legislation. Catherine's our advocate, as she calls herself today. And Catherine really is going to help all of us experts understand what really captures the attention of policymakers. And I think you'll be surprised at some of her thoughts and ideas. Finally, I just really want to thank the ThinkWell communications team, which is small and mighty, but has just put this webinar together and supported us. We are so thrilled to have such a strong team helping us. And if you do have any questions or concerns, please don't hesitate to reach out in the chat and they will help you. Finally, I want to make sure to note that my colleague Martha Coe, who is actually our program manager for the work that we do with MSD on sustainable immunization financing, and Martha has been working on this portfolio for many years, and many of you have probably seen her in other forums talking about immunization financing. Martha is going to be supporting me in capturing all of the questions and making sure that we can get some good audience feedback towards the end of this seminar. So let's go ahead and kick off our debate. So my first question, my first frame, my first paradigm is, for those of us in the public health community, and I would say pretty much everyone on this call probably is as a representative of that, immunization is an obvious no-brainer investment, just like clean water or sanitation. It is not controversial. So if it's such a no-brainer investment, if it's so obvious for governments, payers, and even private employers, why do we see immunization programs not being fully funded or explicitly prioritized in pretty much all settings? And what is it that really matters when it comes to decisions about how immunization gets funded? Dodo, I'm going to take this question to you, given that you've worked at the interface of public health and ministers of finance and service delivery for many years. I'd love to hear your thoughts.
Okay. Thank you, Margaret. I think, okay, one problem, one of the reasons that immunization is probably getting treated like that is it's quite pretty successful. So if you look at it from the perspective of the Ministry of Finance, immunization programs has brought down the cost of vaccines so low. They can do really good coverage, whichever country you are, particularly the countries I work in Southeast Asia, and basically it's been quite effective. And so whenever there are problems with immunization, ministers of finance would just say, it's something that they can solve by themselves. So because it is quite successful, the way it's being organized, it has also been a reason, probably from my previous life when I was in running national health insurance program, that national health insurance programs in many countries, the middle income countries, also say we won't take it on because it's already organized quite well. It's running quite well. And so that's probably the challenge of the immunization program. They have to argue that they can do better. And that has not been coming out from a lot of immunizations program. It's so they're pretty successful. The programs are running well by themselves. So ministers of health basically don't hear the noise to put more resources. At the same time, the program managers are pretty happy with what they're doing, and so they're not really arguing strong enough to ministers of finance. And particularly because when you start expanding, you're talking of vaccines which is more expensive than what's there right now. So they just can't be able to do the arguments quite well. So I think that's probably one of the reasons. We need to help program and immunization programs basically argue the case. And we need the ministers of finance to see the value, the additional value for money that they will get. Sadly, this is probably one of the benefits that we've seen of COVID-19, where basically, the argument that investing in immunization programs can make a difference, and this is something ministers of finance immediately grab. We given the how economies have contracted. So this arguments, this experience should be something that the immunization program should adopt in the coming years. So I'll stop there for now, Margaret.
Thanks, Dodo. And just to make sure I capture what you're saying is in previous worlds, there was a perception that there wasn't a problem. And so why would the Ministry of Finance invest more when there are so many other sectors that really, really need the resources, or at least are better at making the case? And now what I hear you saying is, well, now the situation is very different, painfully so, but the immunization community really needs to take that and run with it and continue to build the momentum and build the case for increased investment in immunization.
Well, yes. And one of the things probably what COVID have done us is that it has desensitized ministers of finance because they're so used to the vaccines being so cheap with the essential programs, right? That they don't want to buy the expensive pneumococcal or the expensive rotavirus. Now, because they're so desensitized with the COVID vaccines, right? So going back to them now and saying, look, although we have dropped this down to 5 cents, thanks Ulla, great job of UNICEF and all, investing $5 now for vaccines for other diseases is something worth it. And you now have the COVID story. But as I said, prior to COVID, unfortunately, we haven't really seen the programs in lots of countries do this case quite well. They have not been quite good. They're a victim of their success. If we use that corny term.
No, it's helpful. Thank you. Thanks for clarifying. Ulla, a lot to unpack there. I mean, you've been working on this for a long time. I'd love for you to just share your thoughts on some of the points that Dodo raised around is the evidence sufficient, or is it, just the problem isn't visible? Why don't you share your thoughts, and particularly your insights as you've observed the globe kind of evolve through COVID, and some of the conversations you're having from your position at UNICEF. Over to you, Ulla.
Yeah, thank you. And sorry, there's a fire engine next to me.
Of course.
But yes, so it will be really interesting to see after COVID, if we get to after COVID, what impact that would have on childhood immunization, deimmunization programs. I think it's too early to say whether that now ministries of finance, politicians will then start understanding the importance of immunization. I think so. I can't imagine that things won't change, but we can't really say yes. So I think what Dodo says is really, really true, that it's kind of a victim of his own success. So I think we need to look at the introduction of new vaccines. That's like a concrete thing that's sort of the obvious. That's also what I've been working mostly on, to try and make new vaccines being introduced. So there you can look at that value, etc. And that's kind of a separate budget from just immunization financing. So immunization financing in itself is part of the primary healthcare system. You don't really split it out. And that's probably also a reason why perhaps the overall budget isn't sufficient. It's part of primary healthcare, and perhaps it's not being prioritized as much. And also I heard immunization managers, there's a lot of evidence of new vaccines. What's the impact of new vaccines? We have epidemiological studies, we have trials, etc. But actually the traditional vaccines, they're old now. And there's no real evidence what will happen if we stop funding them. So some managers have actually requested that evidence, that what about if we stop vaccinating against tetanus and diphtheria? Because they need these arguments to just keep the program running. As Dodo said, that it's just going so well that it's not really being a priority. But with regard to the new vaccine introduction, I would say, of course, the evidence, which you also said in your introduction, Margaret, whether to what extent the evidence is important. I would say it's important to do the studies, but what I found, just to get the advocacy and get it on the table, but the results are not really that important being used. It's just the talk about it. And we've seen in several places that new vaccines are being introduced without any evidence. And then in countries where there's a lot of evidence, they're not being introduced. So it's really not straightforward. It's very political, these decisions, very political.
Absolutely. And I expect we will hear more from Catherine and probably even Stefan on the political decision-making. And that's really what we want to kind of get under with our conversation today, and think about some solutions to that, or at least, platforms that experts and advocates who are all part of the same continuum. We're not divided from each other, but how can we organize ourselves more effectively and sort of speak with the same voice from our different positions? I think that's a really critical point that Kat is going to opine upon later. I do want to just pick up on a point that you made, which is that in terms of the gaps in the evidence that exist, I mean, you noted that there is some retroactive or retrospective evidence that might need to be reviewed in terms of like the traditional EPI vaccines. And then you also noted that there are many studies that are being done, and sometimes introductions or decisions are made with full visibility and use of those studies, and other times completely not. Do you think there's any, other than the sort of political dynamics, do you think that there is a relationship between, funding availability and sort of positive pressure around introduction? So if you're a wealthy country, are you more likely to introduce a new vaccine because the resources are available, or do you just see a lot of variation?
There's just a big distinction between high-income countries and most middle-income and low-income countries, with whether it's a criteria. The phase 4, whether they need to prove, whether manufacturers need to prove cost effectiveness. So I would say in the countries where this is a criteria, like in the UK, in many, I think even in Sweden, when the new vaccines comes on board, there are clear guidelines. I'm sure pharmaceuticals, it's a lot of work and it's tedious for them, but on the other hand, there's a clean criteria. They need to prove the cost effectiveness of the vaccine, and if it's proven, then there's a committee that decides, yes, we will introduce this. So it's much more clear cut. Like they can't really, the government will never buy the vaccine if this evidence is not there.
Right.
So I think in those countries, it's not really that much about the budget availability. It's because budget will be made available if it goes through that process. Right. But in the countries that don't have that official process for pharmaceuticals or for vaccines, then it's all about politics, really. It's about politics. And, you know, I've seen, like, I remember in South Africa, like when rotavirus and pneumococcal came out, it was just the Minister of Health went to the WHO Health Assembly and just said, oh, we're going to introduce these vaccines next month. But, you know, the EPI manager didn't know about this in South Africa. It's just because it was political. It sounded good and it was done then without any, you know, planning for it. So that can also happen. Yeah.
That is an incredible story, an incredible illustration. And it sounds like one takeaway from this is it's not always about advocating for more resources per se. It's also about advocating for more transparent and structured processes that streamline decision making and allow governments to move more quickly, or at least more clearly through the process of reviewing and making decisions about when and how and upon what basis to add new products. It's a really important point that I think often doesn't get talked about in these kinds of forums. So thinking about health systems now, Stefan, I'm turning to you to help us. Actually, Catherine, I'm sorry. I'm going to come back to you first because I think Ulla really raised an important point about politics and sort of why decisions are made and how. In your travels in the advocacy world, what do you think experts are missing when it comes to engaging with the people who control the funds or control the resources, however so we define them?
Thank you so much for convening this panel at such an important time, and hearing from Ulla and Dodo about what happens when a routine immunization program is too successful is that it becomes overlooked. And the scary part from a policy or a political perspective is that in this context, that means if someone, an individual or a voter, you know, finally receives that desperately needed COVID vaccine, and then in that same region or country, having a spike in rotavirus because, you know, it was overlooked. So that's really what's on the dashboard here. And the takeaway for a policymaker is that if you invest in one thing, does that necessarily mean trading off with another? So as the world is coming together this fall, either at the General Assembly, the White House summit that's been just recently announced, or the G20 later this October, as you know, we're contemplating this massive investment in pandemic preparedness. How can that benefit routine immunization, or at a very bare minimum, ensure that they don't trade off? So back to you,
Catherine,
Margaret.
Thank you. I appreciate that. And thank you for noting the G20 summit. And this is something that, of course, many of us have been tracking very closely. As you are someone who works kind of in the space of advocacy and immunization, and even in your role with the Pandemic Action Network, what would you say, you know, experts like ourselves or advocates need to be doing as they clamor for attention and space? And, you know, this is a very, very busy time generally, always, but now it's even more crowded and busy. So if you're someone like Ulla, who has a really incredible breadth of knowledge and connections around the world, you know, what would you advise the health economists of the world, or what would you advise me, right, when all I want to talk about is technical stuff, if I were to have, you know, 2 minutes in an elevator with someone who had a real opportunity to make some decision making? What do I say? How do I say it?
For the health experts, I would say to focus on that investment case that Dodo was speaking to. And for a health advocate, I would say look at other health advocates' agendas. What do you have in common? What can you collaborate with, and get, step out of your silo and see how does routine immunization benefit, for example, preparedness of a frontline healthcare worker, and vice versa. How does pandemic preparedness benefit routine immunization by making sure that that frontline health worker is properly equipped with, whatever appropriate PPE, and see really where you do share common agendas, so that, as Dodo was saying, you can go to a minister of finance and say, hey, this benefits not only my community, but this other important community, and therefore is an important investment.
That's really helpful. Thanks, Kat. And I appreciate you raising the point about PPE and protecting health workers out there, whether it's COVID or otherwise. I think that's another issue that we seldom overlook, where when we're talking at this level, the folks who are really delivering these technologies and delivering these products are likely not top of mind for ministers of finance, and they really, really should be. And I think even in the US context where we're based, we're seeing that come to a head right now, with how underinvestment in healthcare, or sort of misalignment of investments in healthcare systems, have really impacted frontline workers. So thank you for raising that. It's a really important point. So on the topic of health systems, now that I've kind of seized the floor, and Stefan, you and I have worked for many years in our own perches and then together on strengthening community health and community health systems, I would just love to hear your thoughts, especially since we know you from the global context and from working for UNICEF for many years, but as you're now at Karolinska and in your own country, we'd just love to hear more about, sort of your own observations around primary healthcare and misalignment of resources when it comes to getting people access to the services that they really need, wherever they might be. Over to you, Stefan.
Thanks, Margaret. That said, let me start in my low-income country experience, in the sense that I think we've been through a very vertical time period now, where we've had childhood immunizations over by themselves, then we've had the HIV, TB, malaria as their own silos, and then we added a COVID silo now, which has yet to reach low-income countries in any serious way. But we've failed to connect this horizontally and actually to build universal health coverage through primary health care. And I think it's that delivery platform which is really what we need now, also to overcome some of the real constraints in immunization, such as polio eradication, for instance, because you can't go out and expect to immunize people several times a year for a disease they've never seen without offering them any other services. And I think we've learned that over and over. So we'll need that integration at that level. We've had our problems in low-income countries, but we've thrown money at it. We haven't solved some of the issues. But I think in my humble observations, where this really comes to a heed is in middle-income countries, where 5 billion people in the world live out of our 7. 1 billion in low, 5 billion in middle, and 1 billion in high income. It is because the Gavis and the vertical financing mechanisms don't extend to middle-income countries. And that means, as we already heard, that new vaccines become unaffordable because the financing mechanisms aren't there. It also means that I think much as COVAX is struggling to supply poor countries, even some middle-income countries have problem accessing new vaccines, because we have done product innovation without including the access element. Access only happens once you have 3 V's. You need the vaccine, which we concentrate on, but you need the vaccine delivery system, the health system, and the primary healthcare platform, I would argue. But you also need the vaccinee, and you need acceptance, and you need even community demand for these things. And I think we somehow fail to plan for all of those 3 components. And much as it's a problem in low-income countries, middle-income countries have a bigger issue here. And then obviously this gets compounded for scarce commodities, such as the COVID vaccine now, where the 1 billion high-income countries booked out the available vaccine. So even if you have money as COVAX now, you can't buy them. So we need tech transfer, we need more robust production resilient production systems, more than one supplier in more than one region. But I wanted to end up somewhere where Dodo started us. I think that universal health coverage, where the progress is happening in middle-income countries, in my observation, starts from curative hospital care and not from preventive services. And that gives a big problem in the sense that it's hard to make these arguments that Ulla and Catherine can make, because if you're only financing curative hospital care and not preventive services through your UHC platform, it's a harder argument. But it can probably still be made, but it seems to me it's a harder one. And the reason, in my amateur political observation here, Catherine, is that prevention is pretty thankless, because if you're successful, people will forget why you're there, as we started from, and not thank you, and even start suspecting that you're trying to poison them with the very product that saved them to begin with. So the question is, what is it that we can do to build a demand which can then create the political pressure for these new innovations? And I think, for instance, I've thought of myself as a pneumonia advocate for a long time, but I think we've failed miserably to create the demand for pneumococcal vaccine. And as a consequence, major middle-income countries don't include it, even when they produce it themselves at home increasingly. So where's the political economy analysis of immunization, Catherine? Over.
Wow. We could have 3 to 4 more seminars just on each of those points, Stefan. I knew you were going to do that, but I love it and I appreciate it. I think a couple of things to reflect upon, and then I'll do another round to collect some reactions from Dodo, Kat, and Ulla if she's interested. One is this notion of, most of the world's population lives in middle income settings. And within those settings, that's where, and I know this from my work with UNICEF in the past, the equity gaps are massive, even in those settings, right? You have huge populations, and then you have massive inequities at the subnational level. And I think that's one kind of takeaway for me, particularly in this space, is that you can't just look at national coverage rates. You actually have to look at where the breakdowns are happening, even down to the district level, and really be thinking about how to reach people with products and services at those levels. And I think you're right, Stefan, that creating demand is not just like a national campaign. I mean, we are talking about very, very frontline community mobilization kinds of efforts. And there are many countries, well, not many, but some that have actually taken the primary healthcare view to achieve universal coverage and not the curative view. And we see the results. I want to also pick up on a point that you made about the sort of breakdown in what payers are valuing, and like how we create demand, and how the emphasis on curative care, which is largely because I would say the political elite are the ones who are really driving and have the ears of the ministers of health and finance, and that's what the employers want. And sort of that focus on curative versus preventive. And Dodo, I don't want to make you speak for PhilHealth, because you were at the middle of this whole debate and it's continuing in Philippines. But if you wanted to just kind of offer a few reflections on that, you're probably better positioned than any of us to help understand, how challenging those discussions are with what gets covered for whom and at what cost, and how those decisions are made. And then Kat, I'll come back to you on why there aren't more political economy analyses of the immunization space. Dodo, to you.
Thanks, Margaret. I think, okay, couple of responding to your points. I think the first one is that in middle income countries, what doesn't come out, I think, even in media, is how the success of vaccination programs, or relative success, has been driven because of how good the existing vaccination programs are. Okay, what we're seeing in middle income countries is that if Stefan and his friends in COVAX, sorry, I'm having fun here, Stefan, deliver the vaccines, if the vaccines are there, countries could administer it. We're not seeing that fear that when the vaccines come, countries would have difficulty administering the vaccines. We're not seeing that in Asia. Okay, when Mongolia got its vaccines, boom, 60%. When the supply became available in Malaysia, everybody in Bhutan. So this is a great story that nobody is talking about. How the routine immunization program, all this training that UNICEF has done, all these community health workers out there, we underestimated the supply chain. We all said, oh, the vaccines will not be handled by the cold chain. It did. We underestimated the program people that they could not track and allocate. Of course, not perfect. You know, when you have external people, they will criticize they're not doing it right, but they're doing a great job. And this is a story that should come out. The story is all about us, Pfizer, the vaccines came, then that they saved the world. No, the story is you have people on the ground that actually knew how to administer the vaccine in a great way. And frankly, if you double the vaccines now in middle income countries, they can deliver it tomorrow. And they have shown it. And that's what we're seeing right now. So I think, and if this story comes out, then this will be a very strong argument to governments in the future. Look, you know, the infrastructure is there. Just give us more vaccines. Give us the pneumococcal. Give us the rotavirus. We can deliver that. So it becomes now more of the Ministry of Finance. It's now the ball is now with them. It's no longer with the guys, because they have shown with COVID, with this pandemic, that they can do the job. I think going to your second point, look, the challenge we have really, while governments, health programs, health ministries fund curative care, you know, at the end of the day, you know, it's same story with COVID. You know, somebody dying in the ICU generates more, you know, goes into Facebook more than the thousands of people saved from the vaccination, right? So if you have somebody not getting the oxygen, all about curative care, then you know that generates a response, political response, media response, emotional response, more than people getting vaccinated and not being ill. And unfortunately, this leads to allocation decisions. And frankly, you know, this is not something we could solve overnight. You know, it's so easy to say put more money, remove the money from curative care. Unfortunately, you know, the decision makers in lots of countries are, you know, emotionally driven, probably looks at social media, gets pressured by their cousin, so it's you know, it's a continuing challenge for all of us. So as long as we continue, we just have to build a case over and over again. But it's not something we could just say. We have, you know, the evidence all show that they should follow the evidence. Unfortunately, it's not the case. Over. Margaret, over to you.
Thanks, Dodo. Couldn't agree more, and so passionately expressed. Catherine, how are you going to save us all from ourselves? How are we going to get TikToks about vaccines into people's Twitter feeds?
Oh, I think that Stefan raises an important point. You know, noting that he used to be a pneumo advocate, and I think that when we step out of our silos and think more at a systemic level of, you know, when you unify, you are more likely to have impact. When you think of a healthcare worker, what benefits them, what benefits a patient, what benefits, you know, a patient of an array of diseases, that's when you have the most impact with a minister of health or elected official. I think that what Dodo is saying, unfortunately, we do look at the, you know, between 17 and 20 million kids that did receive routine immunization last year. That is what makes political headlines, but that is, again, why we as a collective group need to make the case for linking financing with routine immunization and with pandemic preparedness. You know, it's very rare to have this much political capital and resources as an investment, and how can we make that be most impactful, I think is my takeaway.
Yeah, it's so clear. And I guess myself, I mean, I intuitively know that the health systems of the world are really working at, you know, the maximum performance that they can, right, for COVID vaccine delivery, given the priority that it has and the sort of the resourcing. And I think Dodo's point is just so incredibly made, which is we are, by coming at this from like, well, what are all the problems? We're actually ignoring the better story, which is look how strong these systems actually really are and how resilient they really are. And let's understand why and how we can bolster them and sustain that over time. And, you know, Ulla, I don't want to put you on the spot, but, you know, given UNICEF's, you know, frankly, relentless and powerful emphasis on that very point that continue to invest, do not discount, you know, the people who are at the front lines doing the job that they need to do, and UNICEF's own emphasis on sustainable immunization financing. I mean, what do you see from Dodo's point about how we might tell this story better and how we can use the performance and the investments going in for COVID to really expand it into building up the routine immunization systems and primary healthcare systems that we need for the future? Because things are changing. It's not all communicable diseases, right? There are a lot of things that people need. And I think Stefan's point is well taken. You know, even in very high income settings, if you just come at people with vaccines, but they have a lot of other things going on and a lot of other challenges that they're facing, their trust in the health system is not going to be improved. If anything, it might be diminished. So Ulla, I'd love to hear your reflections, and then
I think what Dodo said is really strong. Like when you think about it, that these immunization systems that are now delivering COVID vaccines, they've only delivered vaccines for infants so far, and suddenly they're reaching all age group, and it is quite incredible. And I think in the past few months, there's been a lot of talk that we need HR surge, we need additional people to help deliver. But what I can see from the countries I've been in touch with, none of them do that. It's the existing people. They don't, I mean, where will they also get extra people from who are trained? So it's actually the existing health workers that delivered the childhood immunization that are now delivering COVID vaccines to the whole population. And yeah, in those Asian countries that have already reached high coverage, like Bhutan, I think it was 50% of their health workers that was just allocated to deliver this vaccine in no time, and they've already reached everybody that's targeted for the vaccine, and as you said, Mongolia as well. So I think that is incredible, and so now we'll just have to see what happens in Africa, and hopefully we can do the same thing, because unfortunately there is just no more health workers to pull in. That's the problem. So we have to rely on that small little cadre that was already there, and it can be a little frightening, I think, for some countries. So we will just have to see when the vaccines, in the next few months, there will be a huge increase of the COVID vaccines. And I guess we just have to hope for the best. Yeah.
Let us all hope. I think that's one major theme that I'm taking away is a spirit of hope and optimism, even in the face of incredible and unprecedented challenges. And I just have so much admiration for all of you who are working on such tough problems, but retaining that sort of inspiring perspective and spirit of hope. I want to have the opportunity to take up, I'm seeing a lot of chats and a lot of questions. And so I want to really open up to the audience. And this is tricky to do, as we've all experienced over the 18 months that we've been on Zooms together. So how we're going to manage this is that my colleague Martha is going to come on screen and give us a little bit of a flavor and a readout of what she's seeing in the chat. And then we will try to direct some questions if they are explicitly tagged. Actually, I saw one specific for Stefan, so we might call that one out for you unless you've answered it already in the chat. But Martha, I'll turn to you to give us a sense of what's happening in the audience.
Yeah, I mean, it's been an excellent conversation. So the Q&A has been active. I'm seeing a few themes that are coming through, and I just want to share them with you, Margaret, and you can direct them to the panelists as you see fit. First of all, there's been quite a few questions. You know, the topic of financing, we've heard procurement come up quite a bit, but where else are we thinking countries need to invest? Where are the gaps existing when we talk about financing? There's been discussions on instilling confidence, on, you know, setting up the systems for implementation, on providing training to workers. A second theme is around how COVID fits into this conversation, especially as we're talking about a potential third dose of the vaccine needed to be put out. How does routine versus that COVID vaccination come together? Another theme around how do we drive conversations and influence these discussions particularly in countries that don't have evidence-driven decision-making. That came up in the conversation quite a bit. And I just saw another interesting question about, to Dodo's point of really harnessing this moment for routine immunization. What does that mean in terms of long-term sustainabilities for these programs?
Great, thanks, Martha. And please do keep the questions coming, just so that folks know. We will be publishing this webinar online. We will also be trying to follow up on some of the questions in a blog following this event. So if your question isn't answered, don't worry, we have seen it, we know how to find you, or you can find us, and we will try to get you that response. But maybe now over to the panelists, and let's take on the question of like, well, okay, so within primary healthcare or within the immunization budget, what are we really talking about? What comprises that whole program, that whole continuum? And where do other investments need to be made, or how might the investments that are being made be allocated more optimally to really drive up performance? And Stefan, since I did see this in the chat, there was also a question, and this relates to this bigger theme about like, what does a resilient production system look like, whether it's for COVID or others? And I think that there really is this big kind of world of what we mean by immunization. And so maybe we can just do a quick tour of the table of what are the most important things that policymakers and decision makers need to be looking at when it comes to broad-based investments in immunization programs. Stefan, I'll kick off with you and then maybe turn to Ulla and then Dodo.
Thanks. I had recently returned to my native Sweden when COVID broke out, and suddenly we didn't have this propofol that puts you to sleep when you go on the ventilator, and Sweden had run out, and we needed to borrow some from Finland and so on. And so I found myself on television having this discussion, and the prep I did then was actually to talk to UNICEF supply division colleagues, and they said resilient production systems and healthy market is more than one producer in more than one region. And then subsequently, as I've discussed on COVAX and so on, someone said, oh, well, but COVAX was unlucky because India closed down its border and kept the vaccines to themselves, to which my preparedness colleague said, but I could figure that out with my pinky 5 years ago, that in a global pandemic, you would close down the borders. So consequently, I've started engaging now from Karolinska Institutet in Stockholm and Sweden in tech transfer in the biotech business to actually see whether we can assist through Africa CDC, the building of production capacity in Africa. However, what I see is that in sort of such capacities need to be sustained in peacetime, as it were, by producing also some of the routine vaccines, I think. And so it comes back to Ulla, I think, actually here, and saying when UNICEF for Gavi makes these massive procurements, we're already buying at the lowest costs, etc. But if we're now going to pay for a more resilient production system, it's going to come at a premium. It will be more expensive to have factories in more continents and places around the world. How are we going to pay for that in peacetime to actually make sure that we have a resilient system in pandemic times, as it were? And that's sort of, I think, one of the innovations that we need to look at now. And I understand, finally, that in the therapeutic feeding space with the plumpy nut, if you know the groundnut vitamin in a bag, UNICEF has over the last decade or so had a strategy to regionalize the production, but it's still more expensive to buy your plumpy nut that way than it were to buy it all from one offshore factory and fly it all over the world. So I think we need investments in these systems to make the products available and more resilient. And that was only a partial answer to the very many rich questions you asked.
No worries, but a really good one. Thank you. Ulla, since Stefan tagged you, I don't know if you have any thoughts or expansions on that.
Yeah, no. Yeah, there's a lot to say about vaccine production, vaccine manufacturing, and if COVID can help expand the companies that produce vaccines, it'll be amazing, because it's true what Stefan says. If we have 4 suppliers for one vaccine and one drops out, it's just really bad. As soon as we have a monopoly, the price is high. We knew that. So for pentavalent vaccines, the price was $360 for 10 years, I think, when there was just one manufacturer. And now we have like 5 or 6, and the price is $70, like 70 cents, 70 cents per dose. So it really matters. And yeah, and that is the UNICEF supply division strategy, to always have a healthy market. This is what we call a healthy market. So even though if a supplier charges more, you want to keep them in the market. And because UNICEF procures so many vaccines, it is our responsibility to ensure that suppliers are kept in the market. Like yellow fever is a good example. There are hardly any suppliers, and that vaccine is often not vaccines to get. Like here in the US, can be a shortage of yellow fever vaccines. It's just nobody produces it, and it's a huge problem. Yeah. But you also asked the question about immunization, and I think ideally everything should be within primary healthcare. I mean, we can't deliver vaccines on its own. It's just a primary healthcare budget, and the primary healthcare system needs to be strong, and that's it. And of course, we procure vaccines separately with its own little budget, and there's a few other things for social mobilization and the cold chain, but everything else is just part of primary healthcare, and that's really what we have to build on. And of course, we know the staff in the health facilities, they just do everything. Vaccines is just, immunization is just one thing they do. They wouldn't start splitting it up as we try to do.
Absolutely. And I think it actually brings back a point that you made quite early on in this conversation, you know, with our starting point, of course, being what's happening with immunization financing. I think, Ulla, you very diplomatically encouraged us to consider immunization financing within the broader context of primary healthcare. And you noted that primary healthcare budgets are quite low or probably insufficient, meaning that the sort of impact therefore on immunization budgets as a component of that budget is also quite low and invisible. And I do agree, and this kind of brings me back to Catherine, and I'll ask you to come in here, Kat. You know, when we're thinking about how to leverage the voices and platforms of others, you know, reflecting upon the component, what is primary healthcare actually composed of, and ensuring that immunization remains kind of one of the key strategies for strong primary healthcare systems. And that we're talking, you know, not just about pediatrics, but we're talking about, you know, everyone across the life cycle. I mean, you know, we tend to think about routine, and Ulla, you noted this, that health workers are used to immunizing, you know, the pediatric population, but of course, we have many vaccines that are underutilized across the life course and across the adult continuum, and even many of the newer vaccines or sort of pipeline candidates would be at a population level, right? Wouldn't just necessarily be for peds. So just thinking about some of these, you know, there's a lot of these messages, they're very complex, but then they're also very simple. And so Kat, you know, how would you advise us as you reflect upon, you know, the conversation today? Like, what can we do? What can advocates, you know, take away from this? And how do we kind of move forward constructively, given that COVID is very much the global priority, and rightly so?
I mean, I would speak to my experience in lower middle income countries, and, you know, as you can see in the United States, as an advocate, I've seen a lot of primary healthcare plans created by advocates that were really fantastic and very comprehensive, but they weren't costed. And until you get into those finance questions, that's really when, you know, it's either, you know, if it's a primary healthcare plan in Uganda, or if you're talking about the US Congress and a piece of legislation, until it's scored by the budget office in the Congress, it is kind of meaningless. So I would really encourage advocates to look at the budget, the line items. Is there, you know, a line item for immunization? How are these things costed? Because that really, you know, a minister of finance is not going to take you seriously if you're not factoring in how much this costs, or if, you know, and take a step farther, if you haven't factored in, you know, all the other costs that a minister of finance has to worry about, and where there are cost savings. You know, as Stefan and Dodo have pointed out just on this call, a few opportunities for efficiencies. So that's would be my takeaway.
Stefan, please.
You mentioned the G20, and actually when I was still with UNICEF, I had the opportunity to attend a G20 health ministers meeting. And maybe this is politically incorrect, but nevertheless, as I listened to the health ministers of the 20 richest countries in the world give their 5-minute speeches, I sat them down and I categorized them. Are they ministers of healthcare or are they ministers of health? And I found that 19 were ministers of healthcare and 1 was a minister of health. So their talk was mostly hospitals and beds and diagnostic tests, etc. Certainly immunization is on the verge there, but very rarely did they get into health determinants and what really creates health. And I think maybe that's one of the issues here. People don't wake up and say, I didn't get polio. What a great day it is. I mean, I don't know that I didn't get polio. So yes, we're suffocating with success here, but how do we make the arguments to people who are thinking healthcare and hospitals and so on? I know these are health economic arguments on the one hand, but also where is the popular demand for this, particularly for new vaccines? And pneumonia is still a killer in many middle-income countries. Are parents aware? Can they really demand this and go seek care for this and saying, yes, I want my kid protected? Over.
It's a really critical point. And, having worked in US healthcare myself, all of a sudden, at least pre-COVID, the sort of Centers for Medicaid and Medicare Services woke up to this reality that most healthcare actually is not, most health needs are not clinical in nature, that a lot of people's health needs come from many other things. And so it really wasn't until, at least in the US, it's sort of the arm of the federal level that finances a lot of our healthcare, started to wake up to this reality, Stefan, that you're talking about, which is, what is health versus healthcare? And I think it goes right back to where Ulla had us start, which is if you are not investing in prevention and primary healthcare and responding to what really catches policymakers' attention, somebody in an ICU bed, you're just continually in this cycle, right, of fighting a fight that doesn't need to exist. It's really about broad-based investment in universal coverage. I wanted to I see my managing director, Dai, who said, which country was the Ministry of Health among the G20? Maybe Stefan, you don't want to expose anybody, or maybe you do.
But I mean, let me be politically incorrect. I'm an academic again. To my utmost surprise, I found the Minister of Health of Saudi Arabia was the only Minister of Health, and he was not a medical doctor. The others were spoiled.
Excellent. Well, the Saudis do invest quite a bit, and indeed, their COVID response is telling, right? They've really kind of put it down that everybody there needs to be vaccinated. I'm mindful of time, and just want to really take a minute to thank every single one of you. And I cannot wait to read all the comments in the chat. I have seen them coming. And I see Dai suggesting that we have a follow-up debate. I'm going to talk to him after this call and see if that can't be arranged. But just so that folks know, we will be posting this on our website. You can go back and listen to these speakers. I plan to, just to make sure that I've heard everything. And really, Dodo, Ulla, Stefan, Catherine, thank you for sharing your time with us today. Thank you for sharing your perspectives. We hope you'll stay in touch. And I'm sure our audience will want to stay in touch with you. So we will make sure that we can make that happen. I'm gonna go ahead and close out, given that it's late in Manila. It's coffee time in Sweden, and it's definitely coffee time in Washington. So without further ado, just want to thank everyone, and thanks again to our funder, MSD, who has supported us with this important conversation, and to our comms team who really helped put all this together. Thanks again, and hope to see all of you soon in the virtual world, or maybe the real world someday. Thank you. Take care.